People often use the term OCD to describe keeping a tidy desk or organizing books by color, but the clinical reality of obsessive-compulsive disorder requires a much higher threshold. A diagnosis dictates that intrusive thoughts and repetitive actions consume at least an hour of the day and cause genuine, severe suffering. These obsessions are what psychologists call ego-dystonic. This means the thoughts feel completely alien and unwanted to the sufferer. They directly attack a person's core values, forcing them to dwell on ideas they find deeply repulsive or terrifying. Because of this, the condition rarely centers on tidiness. The fixations are often paralyzing fears of accidental harm, severe contamination, or intense moral and religious scrupulosity, where a person firmly believes they have committed an unforgivable sin. Treating the disorder as a quirky personality trait actively harms those living with it. A sanitized cultural definition obscures a daily reality of intense fear and isolates those who are genuinely trapped in their own minds. This chart shows how often the medical system misses the mark. Approximately half of all clinical presentations of OCD are misidentified by medical professionals, most frequently labeled as generalized anxiety. This specific error points patients toward the wrong treatment. Generic talk therapy, where a patient discusses their fears and feelings with a counselor, does virtually nothing to stop the underlying neurological loop of OCD. When clinicians miss the mechanical nature of the disorder, they trap patients in a cycle of ineffective sessions. The anxiety persists because the root engine driving the torment remains entirely unaddressed. This rotating flowchart illustrates the underlying architecture of OCD. It is a self-sustaining four-part neurological engine. The cycle begins with an intrusive what-if thought, the obsession. This immediately triggers the second node, a massive, unmanageable spike in psychological distress, labeled here as anxiety. To neutralize that unbearable distress and prevent a perceived disaster, the brain executes a specific action or mental review. This is the compulsion. Performing the compulsion provides a fleeting moment of relief, but this tragically teaches the brain that the compulsion was necessary to survive the threat, strengthening the entire circuit for the next time the thought occurs. A compulsion is never born out of a desire for order. It is a desperate, failing survival mechanism that thickens the walls of the trap every single time the patient uses it. Dismantling this engine requires a highly specific intervention. The gold standard clinical treatment for the disorder is exposure and response prevention, commonly known as ERP. In the exposure phase, a specialized clinician diagnoses the patient to deliberately trigger their specific feared thought or enter the physical situation that causes them distress. Then comes the response prevention. The patient actively refuses to perform their neutralizing ritual. By sitting with the discomfort, they force their brain to unlearn the perceived threat and physically break the cycle. Because this process is intensely difficult, patients are often prescribed SSRIs at doses significantly higher than those used for depression. This lowers their baseline anxiety just enough to tolerate the exposure exercises. Effective treatment is a structured, scientific unengineering of a faulty neurological loop. You cannot talk your way out of it. You have to actively break the circuit. Without this targeted intervention, OCD is a chronic condition. Clinical data shows it rarely, if ever, resolves on its own. The functional cost of letting the disorder run unchecked is severe. Hours lost to repeating rituals destroy careers, erode marriages, and leave individuals isolated. Yet the primary historical barrier to recovery hasn't been a lack of medical knowledge. It has been a severe lack of access. Finding a licensed clinician trained specifically in ERP traditionally meant traveling hundreds of miles or paying thousands of dollars out of pocket. Having a proven mechanical cure means nothing if the patient cannot reach the specialist equipped to administer it. Modern, HIPAA-compliant telehealth directly solves this bottleneck. Secure video infrastructure bridges the massive geographic gap between isolated patients and the specialized evidence-based care they require. Coping and healing counseling brings ERP-informed care directly into all 159 Georgia counties. They integrate with major insurance plans, reducing out-of-pocket costs to $10 to $40 a session, and provide Medicaid access at a $0 copay. By pairing clinical precision with statewide digital scale, the geography of mental health treatment changes. Breaking the cycle of OCD is no longer a luxury tied to a zip code. It is an achievable reality for anyone ready to face the fear.